Hello everyone, I'm Dr. Monica. Today's video will be on alterations in cementum. So alterations in cementum refer to various changes that can affect the structure and function of cementum over time. In this video, we will explore these alterations under four main categories. That is, first category is physiological alterations such as age-related cementum thickening and reversal lines, which are normal changes that occur with aging and tissue remodeling. Second category is developmental or anatomical variations, which include enamel pearl, enamel projection, concrescence. These alterations they are formed during tooth development. The third category is pathological alterations, which include hypercementosis, cemental tears, ankylosis, cemental resorption, and presence of cementicles. These are associated with disease or trauma. And the final category is destructive processes such as root caries and abrasion, which directly damage the cementum. So let's understand the changes one by one. Now coming to age-related cementum changes. Cementum continues to deposit slowly throughout the life, even after root formation is complete. With age, cementum deposition is seen more towards the apical third of the root and in furcation areas. Continuous deposition of cementum, it fills the anatomical depressions over time, which is a sign of functional adaptation and age progression. Conditions like occlusal stress, any altered eruption or drifting, it affects where and how the cementum is going to be deposited, and these patterns they are also more evident with the aging. Now let's talk about reversal lines. It is a feature you will often see in the histologic sections of cementum. These lines they appear as distinct, deeply staining, irregular or scalloped lines. They are called reversal lines because there is a clear shift in the activity from resorption to apposition. This indicates that cementum was altered due to some trauma, pressure, or inflammation, or any kind of pathological stimulus, and then the cementum healed. Now let's look at a developmental variation known as enameloma or enamel pearl. Enamel pearl occurs when remnants of Hirsch cells they remain attached to the developing root surface and they form small enamel-like deposits on the root surface, usually near the furcation area. So these enamel pearls they are considered to be plaque retentive structures, making them problematic in maintaining good periodontal health. Also, they promote localized periodontal disease because they prevent proper attachment of the PDL fibers. Since they appear similar to calculus, but they cannot be removed by scaling and they have to be removed by grinding with a dental burr. Next we have is the enamel projections. Enamel projections, they are flat enamel deposits that appear below the normal level of the cemento-enamel junction, typically in the furcation areas of molars. They have triangular tapering shape and extend apically into the furcation. They are most commonly found on the buccal surfaces of mandibular molars. Their abnormal position and shape can interfere with proper PDL attachment, so they can interfere with periodontal disease management. Now coming to the classification of cervical enamel projection as given by Masters and Hoskins 1964. Grade 1 is the enamel projection extends from the cemento-enamel junction of the tooth toward the furcation entrance. Grade 2 is the enamel projection approaches the entrance to the furcation. It does not enter the furcation and therefore no horizontal component is present. Grade 3 is the enamel projection extends horizontally into the furcation. Now coming to the clinical significance of cervical enamel projections. These projections can increase the risk of furcation involvement in periodontal disease because connective tissue cannot attach to the enamel properly. They also prevent normal periodontal ligament attachment and make it easier for bacteria to grow. Now coming to concrescence. Concrescence is when two teeth become joined together by their cementum, usually after completion of root formation. This often happens during trauma or crowding, which can cause the bone between the two teeth to resorb, allowing the roots to come into contact. So this concrescence, it is often difficult to extract. Next we have is hypercementosis. It is a non-cancerous overgrowth of cementum that is continuous with the normal root surface. It can occur due to cementicles merging together and attaching to the root, or from calcification of periodontal ligament fibers where they insert into the cementum. Now coming to the clinical features of hypercementosis, it is most commonly seen in adults. Its frequency increases with age. It can also occur in younger individuals, especially when there is a family history suggesting a possible genetic or hereditary link. Hypercementosis can result from both local and systemic factors. Locally, it may be triggered by abnormal occlusal trauma, inflammation near the root, or unopposed teeth such as impacted or missing antagonist. Systemically, conditions like cementoblastoma, cemental dysplasia, acromegaly, Paget's disease, rheumatic fever, and thyroid disorders can contribute to its development. Now coming to the radiographic features of hypercementosis. The affected teeth shows thickened or blunted roots. A clear radiolucent periodontal ligament space surrounds the root. A radio-opaque lamina dura remains visible around the area. Usually, there is no treatment required for hypercementosis case, but for multi-rooted teeth, sectioning may be required before extraction. Next is cemental tears. These are small fragments of cementum that become detached from the root surface, or these are fragments of detached bone from the alveolar plate. When these fragments they lie freely within the periodontal ligament space, they can resemble cementicles, especially if they have undergone remodeling through resorption and repair. Next is ankylosis. Ankylosis is the fusion of cementum with alveolar bone, resulting in the loss of periodontal ligament space. It mainly occurs in teeth that have undergone cemental resorption after periodontal inflammation, trauma, tooth replantation, or excessive occlusion force. Over the time, the root may resorb and be replaced by bone, which can lead to absence of physiologic mobility, and there can be lack of metallic percussion, and there can be no proprioception because the periodontal ligament is no longer present in the tooth. Now talking about cemental resorption, although cementum is less prone to resorption than bone, it can be resorbed by multinucleated odontoclasts, sometimes extending into root dentine. There are various causes, for example, by local factors which include trauma from occlusion, orthodontic movement, pressure from malaligned erupting teeth, cysts and tumors, teeth without functional antagonists, embedded teeth, replanted and transplanted teeth, also periapical and periodontal disease. Now we have systemic factors which cause cemental resorption, which include calcium deficiency, hypothyroidism, hereditary fibrous osteodystrophy, Paget's disease, and there are also idiopathic causes. Next is cementicles. These cementicles, they are abnormal calcified bodies found within the periodontal ligament, typically arising from remnants of hairs, usually round or ovoid in shape. The size ranges between 0.1 to 0.4 mm. They can be classified as free, attached, or embedded within the cementum. They may be associated with local trauma, and their number tends to increase with age. Next is root caries. They begin on exposed cementum and dentine, which have a higher organic content than enamel, making them more susceptible to demineralization. It most commonly affects the buccal and lingual root surfaces, especially in areas with gingival recession. Now talking about abrasion, it is the pathological loss of tooth structure caused by an abnormal mechanical process such as aggressive brushing. It usually affects the exposed root surfaces. When it is caused by toothpaste or dentifrice, it often appears as V-shaped or wedge-shaped notch near the cervical margin, just below the cemento-enamel junction. If the video was useful, please like, share and subscribe this channel.